Hi everyone, I have a special treat for you today. In this video, my coach, Kjetil Larsen, is going to coach me on the exercises I can do to improve my posture. He's going to show you the anatomy. It's technical, but I promise it's worth it. Hey Kjetil, nice to see you.
Likewise, Bryan, good to see you as well.
Kjetil and I met about a year and a half ago. We were working together because I had a whole body MRI. And we had a few people look at it, and everyone gave a clean bill of health, the analysis. But then we took it to Kjetil and we said, hey, here's my MRI. What do you think? And Kjetil found a few things in there that were concerning. Specifically, he said that I had some internal jugular vein stenosis. So the pipe inside of my neck, which is responsible for blood flow out of the brain, he identified on the MRI that I had significant stenosis. And that was potentially causing all kinds of other problems in my brain, including white matter hyperintensities and pressure increases. And it explained a bunch of symptoms I was having, such as headaches at night, piercing headaches. And so Kjetil was the only person that was able to piece together from this scan what the symptoms I was having, and not even realizing I myself was having a problem.
So I remember telling you that what are the consequences of this long term? We are still in early stages in research there. Can this have an influence on the development of various craniological disorders, such as early dementia, for example? And I would say it's plausible, and I know that many share that view. So even though you weren't suffering per se, but you were having some headaches, a little bit of brain fog, stuff like that, we started working on that together with Oliver, and well, we had a pretty good result, didn't we?
We had a fantastic result. We corrected the entire thing. So once Kjetil identified this and we started getting additional measurements to quantify what really was going on, we looked at intracranial pressure with eye measurements. We did not do a puncture of the lumbar. We decided that was too invasive for the situation, but we did extensive eye measurements. And then we talked to a bunch of experts on what they would do. We looked at some surgical options to fix it.
Yeah.
And Kjetil said, actually, no, I think you can solve this with posture changes. And this was the first time in my life that I had ever dedicated attention to posture. No one had ever taught me posture before. And so then Kjetil and I started working together on a weekly basis. He showed me a few of these exercises. And I was skeptical that posture alone was going to be powerful enough to correct this. And so I went into it with skepticism, but he told me in about a 6 to 9 month time frame, if I followed his protocol, I would. And that resulted in me being constantly aware of my posture, because it had such significant risks to me of impeding blood flow from my brain. I didn't want to jeopardize that, so it became my nonstop focus of trying to maintain the postural positions that Kjetil has. Now, in doing Blueprint, a lot of people have expressed interest in posture. So this is not a video about posture generally, about Kjetil and I working together to try to fix my internal jugular vein stenosis. All right, so Kjetil, a lot of people have asked me about posture. And of course, my entry point into posture was entirely around fixing this internal jugular vein stenosis. So maybe what would be useful is if you and I just did a session where I did the exercises you prescribed to me, which helped me build the muscles to maintain the posture. And then we basically showcase posture as through our exercises together.
Let's take a few minutes, guys. I would like to do that, if with your permission, take a few minutes and talk about why is this important, because it can sound almost too good to be true. And I think that a lot of naysayers will say, no, it's not possible to improve craniovenous drainage with posture. Well, yes, there is. Yes, there is. There was a study done in 1998 by some famous neurosurgeons, Seoane and Roten. And they were looking into why so many of their patients were having hemorrhages, bleeding in certain positions, and especially a position where they were opening up the skull from the back like this, with the neck extended. A lot of patients were having hemorrhages. And they did a cadaver study. They opened various cadavers, and what they found and what they postulated was that when you bend the neck back like this, which is a common posture for a lot of people, they kind of sit like this and cock that neck back, you block the jugular veins. And that was their theory on that. Now, in the subsequent years, it's not a very popular topic because it has more to do with chronic pain and chronic maladies, which is not a very popular topic in medicine in general. But various papers have come out and been talking about the prevalence of internal jugular veins compression stenosis as a potential contributor to, well, obviously craniovenous hypertension, but also CSI hypertension. So its role in the typical development of intracranial hypertension, the conventional problem, which is a cerebrospinal fluid hypertensive problem. And where I came into this is that I had a lot of patients with migraines, headache, fatigue. They could have vestibular problems, dizziness, vertigo. And a common denominator that I saw, I'm not going to say that this will fix everything, but a common denominator that I saw was this posture. And as I got into vascular ultrasound, I started measuring the internal jugular veins. And research shows that normal flow rates are approximately between 700 and 1,200 milliliters per minute, both jugular veins combined. And I would often find that patient could demonstrate as low as 200, 300, and the lower those total numbers were, commonly the worse the patient's symptoms were as well.
When we go through what you and I did for the PT exercises, and we can just do an exercise and people can just repeat this as they watch.
If you permit, I would like to explain why this works instead of just showing you some exercises. Would you like that? Okay. Okay. I really like explaining mechanisms because instead of just saying that this is how it is. Let me just find a couple of pictures here. So, some examples. So like I already showed you in the MRI, it's not so easy to see for laymen, I guess, but like I showed you in the MRI, what tends to happen is that the C0 or the head glides a little bit back on the C1, and then the C1 glides a little bit back on the C2. The facet joint. There's a famous neurosurgeon called Atul Goel. I'm not sure if I pronounced that correctly. He's an Indian neurosurgeon, very famous in the community. And to the best of my knowledge, he was the first person to identify this, because when you look on MRI in what we call the median plane, median sagittal plane, where the craniocervical junction is, it's not really visible there. But you go out to the side and you look at the facet joints, and that's what I showed you. You can see this, I call it accordion-like retraction, where you see step retraction of each facet joint. Now, how are we supposed to, if each step is back, how do we fix that? Well, the first thing we do not do is that we do not try to correct forward head posture, which is a common fallacy. Because if I try to pull that head further back, it will get worse, of course, but because it's already too far back. Because what people do is that they hinge on the neck, and look at my neck. They hinge on the neck and cock the head back. Do you see that? So although the head might appear to be forward, they're actually hinging back on the neck already. And as they try to pull that further back, it gets worse, not better. So we would like to reverse that, and we do that by making, I got this from a guy called Evan Osar initially, where you make the neck long, not back. You pull up. And you can just imagine when I pull up, the neck lengthens, but my head actually goes a little bit forward. And when you do that, this activates both of the important deep neck flexors. There are three main steps here. The number one is the partial component. And like I said, you don't want to pull your head back. That will make it worse. That can also make other things worse. What you want to do is that you want to utilize the minimal effort. You don't want to tense your neck up. You want to utilize the minimal effort and pull the back of your head up. That will also involve your head coming slightly forward. That's fine. That doesn't matter. That's completely fine. That's step number one. It's very important to ascertain, and you remember maybe, Bryan, we had this, we talked about this, because a lot of patients, when they do this, takes them such an amount of effort in the beginning that they kind of clench to stay there. And patients who have that habit from before, they can do this without it being visible. So you're not going to see them doing this. It looks perfectly fine, but they're clenching to stay there. And the problem with that is that it's very treacherous, because although it looks good, it makes you worse. So what I like to do then, I like to have a third person do a slight torsion on the patient's neck. And this is what we did with Bryan as well. I think it was your assistant who helped you out with that. When I have someone in my office, I put them in a position. And then when they're not expecting it, they cannot expect it, then I just try to turn their head a little bit when they're not expecting it. I'm not twitching it because then it will reflexively tighten up. So I just come in and just, without them expecting it, try to turn them. And if there's resistance, it means they're clenching to stay there. So you have to cue them to stop doing that. So they want to employ minimal effort to stay in beautiful posture. And often the more prominent your Adam's apple is, and the less conspicuous your chin is, the worse it is. So you can just, and it looks better as well. You can probably see the difference between this. Massive difference aesthetically as well. The next step would be the suboccipital exercise. Both the suboccipital and the levator scapula exercises have a requirement of the long neck posture while you perform them. The atlanto-occipital joint is mainly an extension flexion pivot joint, and it has about 30 degrees of motion. This is also very good to do for whiplash patients. So you have the patient first have a long neck, and then you put some pressure on pushing downwards on the forehead. Start with your chin down, and you go up about 30 degrees. If I go further than this, you can see that's neck. Now my entire neck is extending rather than just that upper atlanto-occipital joint. Then I'm going to be doing this, and that's not correct. Okay, so that's the exercise for the suboccipital muscles. Now, for the levator scapula, which, like I said, must not be forgotten here. It's extremely important. Extremely important. You want to be performing. Now, levator scapula is mainly considered an elevator of the shoulders, which it kind of is and kind of not. Levator scapula is mainly a horizontal stabilizer for the shoulders. So the trajectory of pull for the levator is pretty much this direction. Attaches to the superior angle of the scapula, and therefore it pulls the scapula this way. Here's where it gets a little bit more technical, because there are two main ways to move the scapula, and this has to be right to get this muscle correctly. If you have your arms a little bit in front of you, this will encourage what we call upwards rotation, and that will almost entirely disconnect the levator. So we want downwards rotation, which tends to be viewed as bad scapular positioning. That's what we want for this. So we put the elbow backwards. You can see my shoulder blade points forward in the trajectory that I want it to, whereas it points backwards. Do you see that when I pull forward? That's a clue. So I put my elbow back, my wrist back, neck long, and I pull towards my nose with this trajectory. All the way forward and slightly up. And like I said, the trajectory here is mainly forward and slightly up. If I pull mainly up, I will get the upper trap generally. Good as well, but it's not what we're looking for here. If I pull forward and down, I will get the pec minor. Definitely not what we want. So this is the trajectory you're looking for. And I'm not sure if you can see that. Maybe you can, maybe not, but can you see the muscle popping out? Yeah.
How about this? Okay, so I'll do a few of these exercises, and you can coach me as you did before.
Well, what do you want to do first? Let's look at your posture first. Let's do the posture first.
Okay.
And what we can see here is that the Adam's apple is not so prominent. He used to have an extremely prominent Adam's apple, and there's a very clearly delineated chin and jawline. That's what we're looking for here. He's not pulling his head back. Neck looks nice and long. I don't know if you're able to use your right hand, Bryan, and pull some of that hair up so you can see a little bit more of your neck. Is that possible? You can see there. Very nice and long neck. The chin, this is just fine, but the chin could be a little bit higher. But it was fine. It was fine. We just don't want it to be strained too high or too low. So anywhere in that middle escalon is fine. This is very nice. And then we just try to twist him and make sure he's not clenching, which I know he's not.
Yeah.
Now, then for the for the suboccipital exercise, do you want to do that first?
Yeah.
Okay.
Yeah, this guy? Yeah, this guy.
Yeah. So when I prefer for the suboccipitals, the specific suboccipital, I prefer to put the head, the weight on the front. Now, normally here it's good to use both hands if you have the strength for it, or alternate between the two. But due to view here, we're going to use your right arm. Just due to view, all right? You will be continuously pushing down with your hand with the 5, well, this is individual, guys, but in Bryan's case, probably at least 5 pounds of force at least. Not much more than that. And you can see here, it's a little bit too aggressive, Bryan. You're going too high. There we go. And there, perfect. There you go. There you go. Excellent. This one is really tricky. It might not look so hard, but it's extremely tricky to do, and especially if the patient, now in Bryan's case, he knows how to do this, but a lot of patients, they are not able to maintain that long neck position, or they use too much force to stay there, and it's very hard to do this exercise for them without clenching their neck, because we want to do this with minimal force. Minimal force. That's beautiful, Bryan. Well done. Good. Now let's move on to the Levator scapula. In your case, you're in such great shape that we should be able to perfectly see the anatomy here.
So I have these 20s.
Now, 20s might do. For 99% of people, it will be way too much. I tend to use an 8-pounder when I do this in clinic. Now, for you, this might be appropriate. When I do this, I hold a barbell behind my back, but I would never do that with a patient. Now, you've been doing this for a year, Bryan. So we can try with the 20. We can try. Let's see what it looks like. But for the absolute majority of patients, we want to traction both of those Levator at the same time. Now, here's the thing, guys. You want to pull with the shoulders, not with the wrist. So you hold your wrist back, neck long, and you pull your shoulders up and forward. And that looks better than I expected, actually, because this is very heavy. You know, so I have no other patients doing Levator exercises with this weight. Up and forward, up and forward. Beautiful. 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 All right. The only thing I would like to add there, now, you know, Bryan in this case is not a very vulnerable candidate here. But for a lot of patients who are going to be doing this, they should be careful especially in the back part, because when you pull your scapula back and you let it come down, the collarbone will pinch into the brachial plexus. And chronic pain patients, which are my typical patient group, they are very sensitive to this, whereas Bryan is not so sensitive to that. So just be aware of that, guys. I do recommend that we stay a little bit elevated from the start and stop in that position, and we pull up and forward. So when we go back to the starting position, we never go back and down. We just go back, so that we don't ram that collarbone into the brachial plexus. But that was a beautiful presentation, Bryan. Well done. Excellent.
Thank you. You were a great coach. I'm glad we haven't had a session in some time now, so I was worried today that my technique was gonna be trash.
Yeah, but you know, we haven't talked because you're feeling great. And that's how it should be. That's how it should be, right?
All right, cool, Kjetil. I think we can wrap on this. This was fantastic. I just so deeply appreciate you for solving something no one else could solve, and you corrected it, and I got to move on with life, and now it's just a permanence of who I am. So thank you very much.
Thank you so much for that. I do just want to say this one thing, so I'm not, you know, taking the credit from everyone, that there are people that came before me who do surgical approaches for this and do a great job with that. Just want to be crystal clear about that. For example, Nicholas Higgins. And a lot of these patients need surgery, whereas you didn't. So thank you so much for that, Bryan. And, you know, congrats with the great results you had. You really worked for it, and you deserve it.
Thank you, Kjetil. Great to see you.
Likewise. Have a great night.
Thanks for watching, everyone. If you want a shorter 5-step guide on how to improve your posture, click on this video.